You'll pardon me, I'm doing some very rapid editing as we go along. Not having seen all the previous presentations, I'm seeing that we do have some overlap here, and so I'll try not to bore you too much by reviewing things you've already heard. But I would like to start out with one thing that was very important to me when I started my midwifery education. And at the educational program that I did, one of the first things they really drove home to us is, how do you get a healthy population? You start out with healthy babies. How do you get healthy babies? You look after their mothers. And so, to me, all of midwifery, as well as maternity care, but for me, midwifery is looking after the mothers and the babies, and including what's important to them. So that's the basis of the whole midwifery model. You'll see, I talk with my hands. I'm not Italian, but somehow it got there. Okay, I've got what I consider to be a fairly dry topic, which is scope of midwifery care. But what I wanted to do was start out with the international definition of midwifery, and this is a piece of it. I didn't take the whole thing. But this is the scope of midwifery practice as identified by the International Confederation of Midwives. So this is to point out that this is not something that we just came up with. It's not unique to Canada. This is part of a worldwide model of midwifery. So, and in here you'll see that it includes the prenatal care, the care during birth, the postpartum, important tasks in counseling and education, not only for the woman, but her family and the community. It should, preparation for parenthood and extend to women's health, sexual or reproductive health, and childcare. So that leaves a really broad area for us to look at when it comes to the scope of midwifery care. And the Canadian model of midwifery care, which you've heard a lot about all through here, supports all of this. So this is something that you have heard a lot about. So I'm going to skip over this fairly quickly. Autonomous to us means we function independently. We don't require supervision by another healthcare provider as long as we're working within our scope of practice. Primary care provider, I won't beat that any further. Specialists, now I don't think anybody's really come to that, but midwives are considered specialists in normal maternity care, as opposed to the obstetrician, who is a specialist in complicated obstetrics. So, and I guess I should differentiate slightly from family physicians, who also do a lot of normal maternity care, but they are much more broadly prepared. Midwives focus on the woman and the baby. Now, I wanted to also point out that I purposely use the term normal here. Specialists in normal maternity care. That's not low risk. Sometimes you do have to define low risk for certain issues, but for midwifery care, at least in Alberta, and I believe this is across Canada, we do not limit the care that a midwife can provide to a woman who measures in the low risk category on the perinatal risk scoring system. Those have their limitations, especially for the midwives. So you have to look at the whole picture. In Alberta, under our legislation, the term normal is defined by exception. What we have within our legislation is a list of guidelines for consultation and transfer of care. And this basically lists a whole lot of things. I didn't put them up there because I didn't want everybody trying to read the whole list while I'm talking, because it's fairly extensive. But these are conditions that would be considered to take the woman out of the area of normal, which would be then a reason to consult with a physician or transfer care to a physician. But women with moderate scores on the perinatal risk scoring system, and even occasionally with what would be a high score, are still basically healthy women with an uncomplicated pregnancy at the time that she comes to us, even though she has had issues in the past. I can think of an example, a mother that I had who was over the age of 35 at that time and had 2 perinatal losses, which put her in the high category. Those perinatal losses were the result of her first pregnancy, which was a twin-to-twin transfusion. She came to me with her 3rd pregnancy and had a singleton pregnancy that was normal at the time, so that her risk for this pregnancy, those early losses did not carry on to that risk in this pregnancy. She did go on and have a very lovely normal birth. But had I used only the risk scoring system, then she would not have been able to access midwifery care. So that's why, one of the reasons anyway, why we are defining it as normal maternity care. Those women who have significant health issues or complications in the pregnancy would then be referred to the proper level of care for them. Let's see here. And I did want to point out that the reason we consider ourselves specialists is because we, with the educational model that we use, we spend 4 years focusing in on women, on their health, all aspects of reproduction, as well as, of course, the basic sciences, and a thorough knowledge of the normal infant to at least 6 weeks. So that all of that time is spent getting the basics that we need and the knowledge that we need to be able to care for them adequately, to pick up complications at the very earliest time so that they can be managed appropriately before they become a real issue. And it also, as has already been said, it's very important to have the partnership with the women that promotes self-care and health for their infants and their families as well as themselves, and the focus on health promotion and disease prevention that views pregnancy as a normal life event. So, care includes, I'll run through this quickly because it's already been covered to a certain extent. Prenatal care, interpartum care, postpartum care, neonatal well baby care, and well woman care. That is basically what the midwives will be covering. And that then, how do we cover it? How do we decide what that is? So, across Canada, we the Canadian Midwifery Regulators Council had very early on, when they were forming, did the survey of every regulated midwifery jurisdiction, and at this point in time, everybody developed their competencies independently. So they did a survey, looked at all the competencies, and cataloged all of those competencies that were common in every jurisdiction, and that was the vast majority of them. And so that's how we came up with the basic competencies, the basic Canadian competencies. Then, because midwifery is flexible, there are what we are considering advanced competencies. And in my mind, there's 2 levels of those. Advanced, one type is where most jurisdictions have them, but not everybody. Or some jurisdictions. And I'm thinking of things like the ability to prescribe contraceptives. There's several provinces where they have that as just part of their basic competencies. In Alberta, a midwife is expected to be able to do an augmentation, manage an augmentation, an induction, manage an epidural, so that she's not turning her client over to nurses at that point, just because they need that. But that's not in every province. Then there are the other advanced competencies that are basically considered advanced competencies in every province, such things as being able to act as first assistant at a cesarean section, being able to do an external cephalic version, things like that. Those are competencies, or vacuum extractions. Those are competencies that are necessary in some areas, and midwives are perfectly capable of doing them with the correct training and certification. And so each province or territory has the opportunity to tailor their competencies to the situation that they have in their province. I would think in provinces, well, even in the well-populated provinces, they still have the smaller communities without all of the physicians they would need, say, for a cesarean section. And so they will have their midwife trained to be able to be a second, or to be a first assist, which just means they need one less physician for emergency if they have the anesthetist and the surgeon. So that sort of thing allows every province and territory to adapt to their own needs that could be unique to them. Okay, and now then so that's our standards of competency. The other thing that we need with that is our standards of practice, and this sets out how we implement our competencies. Those are the two pieces. I'm talking now as a regulator. Those are the two pieces that we need in order to flesh out our scope of practice. Because, for instance, you could say a midwife has the ability to prescribe. That would be in the legislation. Then the standards and the competencies say a midwife must be able to prescribe medication for this, this, and this. The standards of practice then set out the parameters around what she must do, how she must report it, or limit it, like she can prescribe medication for this for a woman, and that means there's no putting out prescriptions for the hubby or whatever. But that's where your standards of practice come in. So they set out how your competencies are going to be implemented, where they can be done, by whom, under what circumstances, those sorts of things. Now, the last thing I wanted to cover very quickly was resources. Because when you're getting ready to set up a midwifery profession, then it always helps if you're not reinventing the wheel. And so the Canadian Midwifery Regulators Council is one of those resources for regulation. You've already heard from Joanna what they were. And as a developing regulator, the Yukon would not be able to have a full membership, but they could certainly have an observer at the council meetings, and they are a wonderful resource because anything that they've developed that you find useful, you're welcome to. We consider it public domain. There is a wealth of knowledge and experience within the council, so that if you have questions or would like support on something, they're a great resource. The individual provincial territorial regulators, once again, are really willing to help and to provide whatever counsel and support you can, and you have some wonderful examples here of some of those resources. Personally, we found that even regulators from other healthcare professions have been very useful, and I can see, we were talking about nursing here just earlier, that could, some of their experience can be very valuable in how things could work. So.
Questions for Diane?